First of all, let me just start by saying just how much of a honor it is to be back here, to come back home, to come back to this program, to see so many friends and supporters and mentors and teachers over the year. I mentioned at dinner last night that I'm a product of all the teaching that I got here. This was my surgical program, so it really is a great honor. But I just feel content, and for that, I thank you. To be able to experience this is really a very special moment. So let me just start off very quickly. I do want to just say how much of an honor it is to be giving a named lectureship, let alone the George Armanini Lectureship as well today. I saw the list this morning, and I'm glad I only saw it this morning because I certainly do not belong on that list of surgical legends. But this really adds to just the profoundness of this experience as well. As you all know, Dr. Armanini, especially between 1974 and 1978, during his untimely death at that time, had spent a lot of time dedicated to the surgical residency staff at Stanford. And it's just a great honor to be able to give this lecture today, therefore. Quick word about Dr. Hahn. Your hospitality here has just been second to none. You are incredible. You are among the most prominent names in surgery across the United States in all time. And your invitation here really has meant the world to me. And thank you for everything that you've done. And thank you for everything that you've done for this program in particular as well. I just want to give a quick shout out to my class of 2014 as well. We had an interesting class. It was a fun class. I'm sure there are some fun memories. But I also do want to mention Dr. Crummell, who at the time in 2010 took a chance on me as an international medical graduate, no less. And to come to this program and graduate from this program is something that I hold dear to my heart. You'll all see that I let the sub-interns at Harvard know that they should look at the Stanford program, which Keith Lillimo, I think, puts up with sometimes. So with that, I do want to thank all the residents who I worked with, in particular, my co-residents, the senior residents, the junior residents. I mean, I remember even coming in, there was a class of superstars of PGY5s graduating, and Robin Cisco and Maureen Tedesco and that special group of people, Vinita Chandra. And it was really an incredible experience being here. A shout out, obviously, to surgical oncology here at Stanford. When I was here, it was Dr. Norton, Dr. Greco, Dr. Pulsides, and Dr. Visser. And under their care, I learned about surgical oncology and developed this strong interest that I have today. And for that, I thank you. But again, it's really important to mention, and this is something that's unique to this program, is the residents get a very special experience at multiple sites with fantastic teachers. And it really makes you a broader, more diversified product when you come out knowing about the different models of healthcare. And it's something that has served me well in my system today. I just want to honor my father for a moment. He passed away of metastatic colorectal cancer in 2018, actually developed the cancer in 2011, was taken care of by two expert surgeons here. But the importance of that is that not only did I trust Stanford as not just a home for surgical training, but also for care of my family members, but it also allowed me to pursue my interest in metastatic colorectal cancer and hepatobiliary and pancreatic diseases as well. So I give this lecture in his honor as well, and I am hopefully his legacy moving forward. And then a special mention of the important group who I work with at the Massachusetts General Hospital. We have an incredible group out there that has always been innovative and in all ways possible trying to move the needle forward. But a special shout out to Keith Lillimo. Keith has just been an unbelievable supporter. And the line is that if you ever see a turtle on a lamppost, it didn't get up there by itself. He spends every waking hour of his day advocating for people. And I've learned to pay that forward through him. And that really is a very special trait in some people. So I thought I would start, just since I'm an alum of this program, just tell you a little bit about my current focus. So obviously, I'm an HPB surgeon. And through my work, I basically tried to highlight some of the things that I do, of course, first and foremost as a surgeon. But I also have involvement in clinical trials, some that I co-PI and others that I just participate in. I mine institutional and national databases and have an outcomes program that is basically driven by some incredible folks who I've recruited over the years, whether it's residents, research fellows from abroad, or students. And it's basically a self-sustaining machine at this point. I have a very modest basic science effort. And then I've been really involved in, pretty heavily involved in developing cancer programs. We've set up a hepatic arterial infusion pump program. We've set up a cyst program. Once you learn to set up a program, you then can set up multiple programs. And it's been a special interest of mine and something that has been highly welcomed and needed for our patients. But in terms of my non-HPB career focus, obviously I manage the Cancer Center, and I've spoken to a lot of you about that yesterday. But I also have a hand in trainee wellness at the GME. I manage the sub-internship program at Harvard. Probably the toughest job, but if you can do this, you can do anything, is managing the surgeons at M&M. And that's something that I do as co-director of our morbidity and mortality conference at the MGH, which is now a lot tamer than it used to be. But I'm involved in national societies, and then fundraising is really a special aspect of my career. So without further ado, I'm just going to get started on pancreatic cancer. This is going to be a pancreas cancer lecture, but I'm going to try and tell you a little bit of a story today so that I can share with you, and hopefully you can translate into your respective fields a little bit of what we've learned and how we've done this. The crowd here probably needs no introduction to this, that pancreatic cancer is now the second deadliest cancer, and the incidence continues to rise. And the interesting thing about pancreatic cancer is because of the nature of the SMV and the SMA, the vasculature that run underneath the pancreas, there are various levels of involvement of these tumors with the vascular supply. And so you can see here, you have things like venous involvement, venous encasement, arterial involvement, arterial encasement, and generally what we would call either upfront resectable, borderline resectable, or locally advanced unresectable disease. And in general, we don't tend to get very involved in distant metastatic disease, although with a few exceptions these days. The group here needs no introduction. It's always like bringing coals to Newcastle, as they say. Pancreatic cancer at Stanford, almost a world-renowned experience with the management of some of these more complicated tumors as well, especially the borderline resectable. And just want to acknowledge some of the great work that's been done by also Dr. Polsides with the fluorescence-guided imaging surgery as well. So the story begins with this. This is the 1985 to 2006 experience of the MGH. This was before I got there. And what happened here was, in a group of selected patients, the overall survival was analyzed. And among 499 resected patients, the 5-year survival was 19% and the 10-year survival 10%. And so this, again, the emphasis is in a selected group of patients who had no metastatic disease with a 5-year survival of less than 20%. And so at the time, we looked at patients who underwent what we call an R0 negative margin resection, which is wide margins greater than a millimeter, and compared them with patients who underwent close margin resections or positive margin resections. And no surprise, median survival is 35 months versus 16 versus 14. And so really the only thing that made a difference here was having a negative margin resection. That was important, that was imperative, and that had implications for borderline resectable disease and locally advanced disease. You can't just shave these tumors off or try and debulk them. The patients do not do well if that's the case. In fact, when we compared patients with an R1, i.e. microscopic positive resection, to locally advanced patients who were not resected at all, the median survival was actually very similar, 11 months versus 14 months. And in fact, there were several studies, this is around the 2010-2011 era, that showed the importance of margins on predictors of survival. And so at the same time, what was happening is there was some great work that was being done in the metastatic setting. Now, traditionally, gemcitabine single agent is what was used to treat metastatic pancreatic cancer. And at that time, there was a proposal to try this new triple regimen, what's known as modern systemic therapy now, with 5-FU, oxaliplatin, and irinotecan, or FOLFIRINOX. And this became the standard of care for pancreatic cancer because of the improvement in overall survival and disease-free survival, or progression-free survival. And what those refer to is recurrence. And you can see here, there's a big separation of the curves, especially for pancreatic cancer. That's considered a pretty wide separation there. And so the question then that came to mind is, well, if we can do this in the metastatic setting, why not do this in the borderline resectable and the locally advanced setting? And I'm going to focus my efforts a little bit on those. And can we use FOLFIRINOX in a neoadjuvant setting? And neoadjuvant means giving the chemotherapy before surgery, all right? As opposed to adjuvant, which means giving it after. And the case for giving neoadjuvant therapy would be that this would allow us to do a negative margin resection and would help with tumor and node downstaging. But importantly, it would also ensure that patients are getting their chemotherapy, because about 25%, even 50% in some series of patients cannot see chemotherapy because of complications from operations like Whipple that have an inherently high morbidity rate. And it could be anything up to even things like surgical site infection that could delay the receipt of chemotherapy. But we know that pancreatic cancer is also systemic disease, and that made sense. And there are a lot of other more minor advantages of doing neoadjuvant therapy. So this was one of the first cases that was attempted at MGH. And this is a 41-year-old patient who had a 3.6 centimeter tumor encasing the SMA. And you can see here, this is a tumor that's in the uncinate that extends through the root of the mesentery there and encases the SMA in this gray fuzz that you can see here. And the CA19-9, which is the tumor marker used for pancreatic cancer, is 985. And this patient underwent, in our regimen then, FOLFIRINOX for 4 months, and then 50.4 gray of chemoradiation. The CA19-9 dropped back to normal range, 37, and this tumor came out. It was a 1.6 centimeter tumor, T2, N0, negative margins, despite the fact that on the pre-op imaging, you continue to see the involvement here. And what this was just basically fibrosis that was left behind from the chemotherapy. And we started to see that more and more as we attempted these cases. And I think this is probably one of the most important papers that came out. I give credit to my partner at the time, Dr. Christina Ferroni, who's now chair at Cedars-Sinai. And she published this paper, and the aim of this study was to evaluate the accuracy of imaging now in determining resectability, because we were taking those patients to the OR and they were getting resected. And how could that be? And in fact, what Dr. Ferroni described at the time was that imaging is completely unreliable. In fact, 92% of patients underwent an R0 resection despite being deemed unresectable. In fact, in 16% of patients, there was less than 1 millimeter of residual tumor at that time. And these nests were probably dormant, and even when there was viable cancer, they probably couldn't grow back because of the alterations in the microenvironment. And so we analyzed at the time and compared with patients who did not receive neoadjuvant therapy. FOLFIRINOX resulted in longer OR times, and these operations initially were harder. There was higher blood loss. But one thing that was striking was that there was lower operative morbidity. And I guess by frying the pancreas with radiation, there were no pancreatic fistulas at all, which is the Achilles heel of this operation. And so in 50 patients that were described in that series, there was 0 pancreatic fistulas, which was unheard of for pancreatectomy. There was also a decrease in lymph node positivity, smaller size of tumors, and other findings, but essentially equivalent length of stay, readmissions, and mortality. So here's a patient of mine, having just come straight out of fellowship. To be faced with this kind of patient was definitely a little tormenting experience. But you can see here a huge tumor that comes out of the uncinate and extends across to the left side of the body. There's the aorta. And you can see here the SMA and the SMV. And this patient underwent neoadjuvant chemotherapy with the same regimen that I just described. And there was some continued fuzz here around the SMV perhaps, but certainly around the SMA. And you can still see this tumor extending over to the left. And importantly, this tumor came out. And what you can see here is when we took this tumor out, there was basically no evidence of tumor left behind on the portal vein and the SMV or the SMA. And you can see here that the right side of the SMA is divested and skeletonized. And this patient had a YP-T1C node negative margin resection tumor. But the important thing that I want to point out here is we did not need to do a vascular resection. We're able to shave off the fibrosis, essentially, off these vessels and skeletonize the vessels. And you can see here the pancreatic stump, you can see here the common hepatic artery, and then the bile duct is just up there. So we decided at the time to look at predictors of resectability and survival. And I became a lot more active now at the MGHC in trying to get involved in research. And we thought we'd try and explore and see what could help us predict if patients could be resected or not. So we compared those who were resected versus those who were not resected with respect to CA19-9 and tumor size. And what we found, actually not much difference, not very helpful data in that both resected and non-resected patients had a decline in their CA19-9, arguably a little bit more in the resected patients, but also there was a decline in the size of the tumors, again, arguably a little bit more in the resected patients, but both went down, okay? And so at this time, we decided to start looking, and we found that patients who got FOLFIRINOX seemed to be living longer than those who didn't get any neoadjuvant therapy. And that makes sense, because at this point, we're putting them through a tumor biology test, and those who metastasize are being excluded from an operation. So you might say, well, this is all selection bias, and the answer is yes. This is actually what we need to be doing for pancreatic cancer, and this was fine. But now we were starting to see survivals of 43.7 months median compared to 25 months in the non-neoadjuvant arms. And this is probably the most important slide that I'll show, which is one of the things that we got criticized for, is that could it just be all the chemotherapy and the radiation that's doing all the work, and what are surgeons doing in this setting? And the answer is something. And the reason for that is when we looked at resected versus unresected patients, and again, there is a little bit of selection bias in this, you can see here there is some big separation in the curves. And in fact, resected patients had a median overall survival of 43.7 months like I just showed. The unresected patients had 18.6, so about 2.5 times improved survival. And I'm going to come back to this slide in just a moment. So at this point, we decided to run our first phase 2 trial in borderline resectable patients and tried to prove on paper that our regimen works. This was FOLFIRINOX 8 cycles, 4 months, once every other week, chemoradiation, and then surgery. And our negative margin resection rate in the borderline setting was 65%. And resected patients' median survival was not reached at the time of analysis, and our 2-year overall survival was 72%. Now, at the same time, the Steele laboratories at the MGH were looking at losartan. And losartan is an angiotensin receptor blocker. It's an antihypertensive drug. And what they found at the time was this inhibits collagen 1 production through the TGF-beta pathway, and that this would inhibit collagen, the cancer-associated fibroblast production of collagen in breast cancer specimens. And you can see here, there was a lowering of active TGF-beta and collagen 1. And what they found was that losartan actually decreased collagen 1, and with it, the size of these tumors, and improved the intratumoral distribution of nanoparticles. So there would be more access through improved blood supply. So the first thing that we did when we saw that is we went back and looked at our patients, since many of our patients are on ARBs or angiotensin-converting enzyme inhibitors, and found a big survival difference retrospectively in those who got some of these drugs compared to the patients who did not. And immediately we noted a signal here. So when you see a signal, you try and move this to the prospective setting, and that's what we did. So now we pursued our locally advanced unresectable trial. And these are more active tumors that are larger and more geographically awkward in that they probably encase the SMA, for example. And so we did intervention again, FOLFIRINOX 8 cycles, same chemoradiation, but we added losartan for these more advanced tumors. And now we found that the R0 resection rate was 61%. And this was remarkable because 10 years ago, those patients would never have been considered for a resection of what they had. And in fact, our median overall survival for resected patients was 33 months, and now the 2-year overall survival is 83%. And in fact, when we compared both phase 2 studies, so when I say phase 2, I'm going to be referring to these studies, we found that there was actually a similar resection rate, 65 versus 61%, despite a more advanced stage. And in fact, there were 3 complete pathologic responses in the locally advanced study over the borderline study. And the median tumor size was 4.9 centimeters in the borderline study, but 1.8 in the bigger, more advanced, locally advanced study. So we decided, obviously, that losartan warrants further study. And I can tell you, when we used to go to the OR, you could tell when a patient had gotten losartan, their tumors would be softer, pinker, and they wouldn't be as hard, white, and fibrotic. And you could tell that they had improved perfusion, and they had responded much better to the chemotherapy. So at this point, we launched the phase 3 trial, which is a multi-institutional trial. And again, FOLFIRINOX 8 cycles, radiation, and surgery. In the second arm, we had losartan. And in the third arm, we decided to combine losartan with immunotherapy. And it was a very intentional design to have the primary objective be a resection rate of greater than 65% to try and achieve a positive study. And the results from this are actually just being written up at this time. This study is now officially closed. And this was the first case on study. It happened to be my patient, a 66-year-old healthy woman who presented with vague right upper quadrant pain. She had a history of laparoscopic Roux-en-Y gastric bypass. We're seeing more of those patients now present for Whipple. And she was a radiation oncology nurse at the Brigham. And this was her scan. And when you look here, you can see the 360-degree narrowing of the vein there. All right. And so she went on to get FOLFIRINOX, chemoradiation, losartan, and immunotherapy. And you can see here, after treatment, her vein just pops wide open again. And this was the picture from the operating room. Once again, you can see the skeletonized vessels, the portal vein, and the SMA. You can see a left hepatic artery going over here. And she actually had a right hepatic artery that was actually conventional, not replaced, but ran underneath the portal vein and the IVC in the left renal vein. And again, importantly, we did not need to perform a vascular resection. And her pathology showed a YP T0 N0 complete response at that time. So we're very encouraged by that. And I have a small lab effort. And we decided to go from bedside to bench and take a look and see what we're seeing with losartan there. And my postdoc from China, Dr. Chow, who I give him a lot of credit for this excellent work, had developed an orthotopic mouse model of PANC1 cell line. And we developed a radiation model that would shield the mouse, but leave the tumor exposed to the radiation. And we decided to do radiation because the Steele lab had done chemotherapy, and there was some other work on the chemosensitizing effects of losartan, but never with radiation. And you can see what we found here was with radiation 6th grade, there was shrinkage of these tumors compared to controls, and more so with 12th grade of radiation. But when we combined with losartan, the effect was dramatic. And you can see here the synergistic effect of losartan plus the radiation, especially with 12 gray of radiation. We have an incredible mouse MRI facility. This is a skill that I'll probably never use for anything else in my life, but we learned to do it nonetheless. I'm basically omitting about 100 slides of a lot of work that went into this to try and get to this final phase that we're at. But you can see here with radiation, a little bit of shrinkage of tumors. When combined with losartan, more dramatic shrinkage. Add in 12 gray radiation, some shrinkage of the tumor, combined with losartan, the tumor was invisible at this point. And in fact, we think we stumbled upon a little bit of an interesting finding in that what we found with radiation was angiotensin receptor 1 receptors were being upregulated with radiation. And oh, by the way, that may have been the way by which radiation can cause eventual resistance to treatment, in that it can increase the fibrosis. And this is what you would expect in the deposition of TGF-beta. But what losartan did at this point was actually ameliorated that finding. And this is probably why we were seeing some of these tumors be softer and easier to navigate in the operating room as well. So another fellow of mine in the lab at the time decided to now go back and explore the predictors of resection, because this would be the most important finding that we could share. And he looked at tumor size reduction and CA19-9 kinetics after neoadjuvant FOLFIRINOX. And what we found now, with an increased sample from the original publication to 193 neoadjuvant patients, was that tumor size reduction was very important. And the hazard ratio of 1.02 actually means a 2% chance of getting the tumor out for every 1% chance reduction in size. So if a tumor reduces by 20% in size, there's a 40% increased chance of being able to resect that. And with it, the pathologic near complete and complete pathologic response rate as well. And then the second thing that he found, which was really important, was that CA19-9 normalization specifically, not just decline, was strongly associated with resection. And then subsequently, obviously, and this makes sense, that postoperative CA19-9 rises in those patients would correlate with recurrence of tumor. So there's no question in my mind that we made a lot of progress when it comes to the borderline resectable and the locally advanced pancreatic cancer patients. And again, 10 years prior to that, these are patients who were not even being considered for resection. And that the neoadjuvant strategy was a great one based on the metastatic data that has now allowed us to translate this into all kinds of pancreatic tumors. And we think at the MGH that you should always combine those with losartan because it really has an impact. So the question is, where do some of the controversies lie today? And one of the questions is obviously neoadjuvant for upfront resectable disease. And there are some ongoing trials, including the Alliance and the Dutch trial, that are looking at this, but I'm going to share a couple of slides of data, the role of radiation, and I want to talk just a little bit about the local approaches. So in terms of neoadjuvant for resectable disease, this is a very important study that came out in 2021. It was published by the, I believe it was the Alliance group at the time. And what they did was they randomized 147 patients, and they were comparing two systemic chemotherapy regimens, FOLFIRINOX versus Gem/Abraxane. And what they were able to show, first of all, just to mention, this was supposed to be a neoadjuvant study, but actually ended up being a perioperative chemotherapy study. And what that means is, while most patients got neoadjuvant chemotherapy, they didn't complete the entire course like we do, 8 cycles, but they actually did some on the back end. So they did adjuvant chemotherapy as well. And what they showed was that the R0 resection was the same between the arms, but it was very depressing because suddenly we're seeing disease-free survivals of 10 months and 14 months with neoadjuvant therapy. How could that be? We thought we'd just revolutionized the field, and it looked like we'd taken a step backwards. And in fact, their data then subsequently went on to show that the overall survival was only in the 20-month range for both arms. But as they say, the devil is in the details. And when you look carefully here, and this is a little bit of a problem with multi-institutional studies, is that only about half of the patients in each arm got resected, which makes no sense for an early upfront resectable study. And part of the problem with that is that it's really hard to control what surgeons do on a multi-institutional basis and who's willing to be aggressive in the neoadjuvant setting versus not. And it's really hard to control the standard of surgery that's being offered to the patients as well. And so again, if you go back, you remember the importance of resection from that slide, those who got resected versus those who did not, and chances are those who did not diluted the sample significantly there. So armed with these data, we decided to go back and look at all our patients now with Zivan Fong, who many of you may know is now an attending at Mayo Clinic in Arizona. We looked at all our patients who got neoadjuvant FOLFIRINOX, but in a non-clinical trial setting, because we wanted to provide a real-world analysis of what these patients look like. So again, the aim was to analyze on an intent to treat real-world experience. And really the only exclusion criteria that we used here was that the patients are on an ongoing clinical trial. So these are just all our patients, including, by the way, at satellite affiliate hospitals. It's really hard to go through all pharmacy records to kind of, figure out who all the patients were, because a lot of our patients get chemotherapy in the community and then come back for their operation. But we did that. And there were 254 patients at this point. You can see our sample size continued to grow who were initiated on FOLFIRINOX. And of those, 199 underwent exploration, 142 were resected, and 129 of those were cleanly resected. These are R0 resections. So when we looked more carefully at those patients, only about 16% of those were upfront resectable patients by NCCN criteria. And that makes sense. We do get a lot of borderline and locally advanced cases now. Case of be careful what you wish for when you start publishing data like that. But you can see here that our locally advanced unresectable patients constituted 52% of this cohort. But we learned a lot of things from this study. This turned out to be a really important study. And what we learned, first of all, is that the majority of patients who started chemotherapy were able to finish it. And by finish it, I mean the 8 cycles that we designated was the standard of care at our institution. But again, we're a very radiation-heavy institution, and 86% of our patients got and completed radiation therapy. Now, we found out that the reasons for not completing chemotherapy were poor tolerability and disease progression in approximately 60% of patients. And then we even looked at frailty scores through ECOG and found that the majority of patients did not change, but some became frail. In fact, a significant proportion of people getting chemotherapy before Whipple's, for example, were getting more frail. We found that a significant number of patients had grade 3 and grade 4 toxicities. That's a very high proportion, over 40%. About 30% of patients had to come back to the ED for a visit during chemotherapy. About 40% of patients got admitted at least once to the hospital for an average of 4 days, some up to 9 days. Half of the group was biliary stented for jaundice beforehand, so they need the stent because they're going to get neoadjuvant therapy. But about a third of those patients required additional ERCP. And we always talk about the risk factor of cholangitis and how that can impact the treatment. So a third of patients had developed cholangitis and needed repeat ERCP. What we found overall was that the tumor size had shrunk from 3.2 to 2.5, CA99 average 164 down to 36, and about 23% of patients developed progressive disease, and the rest with some kind of response. Surgical margins, negative margins, 90% of the group that underwent exploration, 129 patients, and we learned that 8 of those patients had a complete pathologic response. So our complete pathologic response rate is 5.6% with our regimen. Average number of lymph nodes examined was 19. Average number of positive lymph nodes was 0 with our strategy. And with it also, we found perineural invasion and lymphovascular invasion rates that we documented. And then came a couple of important findings. Now, we found that patients who did not complete FOLFIRINOX for any one reason or another could not tolerate the treatment were not associated on multivariable analysis with worse overall survival. But what we did find, and not surprisingly from everything that I've just said, that patients who did not make it to the operating room were associated with worse overall survival. And again, going back to that same slide, if you get resected, you do well. If you don't get resected, you do badly. And we looked at the predictors of not undergoing exploration, things like social factors, receipt of prior chemotherapy, and completion of cycles itself can be a predictor of not undergoing exploration, but itself did not have a direct impact on multivariable with worse overall survival. Increase in ECOG score and locally advanced disease were the predictors of not undergoing exploration. And then we also answered the question using this study and looked at over 75-year-olds versus under 75-year-olds and how safe it is to start chemotherapy in them. And what we found was that while more of them, approximately double, did not complete the chemotherapy regimen, they all made it to the OR at roughly the same rates. And so we deduced that it was safe to start chemotherapy, even in elderly patients and octogenarians today, who we see many of. And you can pivot easily and go to the operating room as needed, when needed, or convert straight to radiation if they're not tolerating chemotherapy. So from that study, 254 patients, 199 explored, 142 resected, 129 clean resections. And despite 42% of patients having a grade 3 or 4 toxicity and a third requiring additional ERCP, we could still get most of these patients to the operating room. So we felt that neoadjuvant was safe. And this was a real world analysis, and we decided to push forward with this. Now, people always say there's no data to support the use of neoadjuvant therapy in upfront resectable disease. Not true. There might be data we don't like, maybe because they're not from here, but there are data. And this is a paper that was done and published in the Japanese Journal of Clinical Oncology. The full manuscript is still awaited, but this is a phase 2/3 trial of neoadjuvant chemotherapy. In the Far East, they use S1 with gemcitabine versus upfront surgery. And neoadjuvant versus upfront surgery, 362 patients, 182 in the neoadjuvant arm, 180 upfront resection, and the median overall survival was 36 months versus 26 months without any difference in secondary outcomes. So there is benefit that has been documented in a prospective trial with neoadjuvant therapy. So radiation, I just want to talk about this a little bit. And we are a little bit different, I acknowledge, from many other institutions in our heavy use of radiation. Now, no pancreas talk is complete without mentioning PRIOPANC, which is a Dutch study that looked at chemoradiotherapy versus immediate surgery for resectable and borderline resectable disease. And what the authors of that trial showed was that preoperative chemotherapy compared with immediate surgery had a benefit on both overall survival and disease-free survival. So what's the issue with radiation? Why don't we all use it? Well, this is probably the most important study that has changed that. And this is the efficacy of preoperative FOLFIRINOX versus FOLFIRINOX with radiation that was published by Matt Katz, who I'm a huge fan of, is a great person who does pancreatic cancer work at MD Anderson and is the chair of surgery there. And this phase 2 randomized clinical trial unfortunately showed this. Patients who got chemotherapy plus radiation compared to chemo alone did worse. So radiation impacted survival adversely. So how could that be? It's a modality that helps treat cancer, yet those patients are doing worse. Once again, this was the huge issue here. In a multi-institutional trial, the R0 resection rates and the number of people who were resected in the FOLFIRINOX plus radiation group were substantially lower. And once again, back to this slide. If you get resected, you do well. If you don't get resected, you don't do well. And it's really hard to run multi-institutional surgical trials and control the standard of surgery that's being done at all these institutions. In fact, when the PRIOPANC authors went back and looked at the long-term survival data, and now what they did in this study intentionally is they excluded the patients who then had progressed and recurred in the liver and other distant sites and looked at the impact of local recurrences. Those who got radiation beforehand had a much lower local recurrence rate and with it a survival advantage. All right. Now, the importance of that is radiation has only rarely ever been shown to cause a survival advantage. It reduces local recurrences. Aside from breast, arguably, I was talking to Dr. Wapner about this yesterday, and she says it's plus minus, prostate, and short course rectal. But besides that, radiation has not been shown to improve survival. And this was one of the first times on the long-term follow-up that we were able to see the reduction in local recurrences and with it improved 3-year and 5-year overall survival. So again, the problem with most studies, especially in pancreatic cancer, is we only look at the initial phase under 5 years. And the analyses don't extend to beyond that. But when we do see this impact of radiation there. Now, there are some inadvertent benefits that we found with radiation at the MGH, which is that it provides an important tumor biology test between chemotherapy and surgery. And it actually allows us to exclude some of the additional patients who may have aggressive tumor biology, who as soon as you take them off systemic therapy may meta out. What happens is they get 5.5 weeks of radiation. There's a pause for 4 weeks. So there's a 9-week window that we allow those tumor biology performers to declare themselves. The other thing that we found is that it lowers pancreatic fistula rates. And again, this is great because this is the Achilles heel of these operations. And when patients have morbid complications, it tends to be related to fistula. But the final thing that we saw, and now this is something that we've experienced in our patients who get radiated, is we don't see pancreatic cancer pain anymore. And we have rarely had to perform celiac axis plexus ablations, for example, with alcohol. And it's probably because we're targeting the celiac plexus with the radiation treatment that we offer as well. So just a little bit about the local approaches: arterial resection, divestment, automatic vascular resection, and IORT. So I mentioned we love radiation. We really love radiation, by the way. So we even give radiation in the operating room at the time of resection, what's known as intraoperative radiation therapy, IORT. And I attach these pictures only to show you what it's like to actually place the beam on top of either the surgical bed or the tumor, and then we roll the patient back about 5 to 10 feet into the Mobitron radiation machine in the operating room. And the clinical advantages of this is it allows us to have direct visualization and allow for accurate definition of any target volume. And normal tissue can be removed or shielded from radiation. Since we're open, we're in the operating room, we can see exactly where we're targeting the beam. And we use electrons, which allows for adjustment of the depth of the radiation beam. So the question is, what do we use radiation for, and do we use it on all patients? And the answer is absolutely not. But when we do use it, it's for these locally advanced tumors, and especially because I told you that we tend to not resect these vessels. If we feel, based on subjective assessment by the surgeon, that there may be threatened margins or tumors left behind where there could be microscopic tumor cells on the vessels, then we go ahead and deliver a 10 to 12 gray of radiation at the time of surgery, but also for unresectable disease. And so, for example, you get in there, the tumor's still as large as expected, the response has been relatively poor, can't create the tunnel. Sometimes we actually biopsy around these vessels, and if the biopsies come back positive, we declare them unresectable at the time of frozen analysis in the operating room. We go ahead and combine this with a gastric jejunostomy because you get severe inflammation at the site of the duodenum from the radiation, and we deliver a slightly higher dose of 15 gray. So just to put this into perspective, the single dose of electrons at about 15 gray, if we're talking about 50 gray over 5.5 weeks, it's about a quarter to a third of the dose that's delivered over 90 seconds in the operating room. It's a pretty high dose of radiation. So this was actually initially started by Dr. Warshaw, who was a big believer in it. And this was the early analysis, 1978 to 2010, of unresected patients with locally advanced disease. And you can see here, median overall survival is 12 months. By the way, I just showed you some incredible numbers of 2-year overall survival of 72 and 82% here, 2-year survival of 16%. But there was a small tail on the curve. 5-year survival of 3%. Now you might say, well, that's not. But those are patients who had a response without resection from the radiation alone. So we looked at IORT. I'll give John Harrison some credit here. I see he's the fellow here who we're recruiting back to Mass General, who did this wonderful paper that was published in Annals of Surgical Oncology looking at the modern era experience with IORT. And what we found was that when you combined IORT with resection, now we're starting to see survivals of 46.7 months. This is another important finding here. We found that patients who got IORT alone for unresectable disease had overall median survivals of 23 months. Now, the importance of that is compared with historic Whipple operations, that is the survival from our traditional approach to Whipple followed by adjuvant therapy, at least followed by adjuvant gemcitabine. So we've achieved that just by doing radiation, and without resecting the tumor, we're matching historic data from Whipple's and adjuvant therapy. So in terms of the summary for IORT, it was well tolerated with minimal complications. IORT alone was associated with similar outcomes to historic upfront surgery and long-term survival for a small number of patients here. And the addition of IORT to locally advanced patients who've undergone neoadjuvant therapy is associated with the highest overall survival that we've experienced today. And so this is our current approach at MGH. We do total neoadjuvant therapy, FOLFIRINOX for 8 cycles. We try and do long course chemoradiation for all our patients, which, by the way, we prefer over SBRT or short course radiation. The reason we do that is these short courses tend to be associated with more fibrosis, and especially if you delay the operation. Whereas this is a smaller daily dose for a longer period of time. Actually, when we go to the operating room, you're basically cutting through edema planes, and you can bovie most of your way through the Whipple specimen coming out, essentially. So it creates this really nice edema plane that you can cut through, and we've got it down where we basically try and operate at exactly the 4-week window after radiation. So chemoradiation, 4-week pause. By the way, the radiation continues to work during that time, and then they have their operation. And then afterwards, they recover, and there's no further treatment on the back end. So they're all said and done after their usually Whipple surgery for this approach. In general, how we decide to go to the operating room, if there's no progression, we explore the patients. That is the only criterion that we have, absence of progression. And we proceed with operative exploration. If we see a shrinking tumor size, that's a very good prognostic factor for ability to resect, as is CA19-9 normalization. And we're seeing that increasingly now since the publication of our paper, that normalization is a really strong signal for being able to resect. We perform intraoperative biopsies where possible, especially if we see any tumor coming out through the infracolic compartment and extending down the root of the mesentery. And if positive, we proceed with IORT for unresectable disease. But if negative, then we continue and proceed with resection and vascular skeletonization. Of course, are there times where we get in there and you can't explore the right side of the SMA and tell if there's a tumor involved? That is definitely the case, and you can only find out once you've cut the pancreas at the neck. And then we have IORT backup for these locally advanced cases for margin accentuation as needed. So looking back at our phase 2 data now, so now we have some long-term follow-up. And at 5.2 years, here's what we found. The median overall survival in resected patients now is 46 months. And out of 66 patients who were resected, 23 remained with no evidence of disease. That's a third of the cohort at 5.2 years follow-up. And our 5-year overall survival now is 40% for pancreatic cancer. Now, I just want to mention a quick word about arterial resection, and there are groups who perform arterial resection all over the country as well. And I would say that probably this publication from Mark Trudy, Dr. Trudy has probably done more of these than most at this point, but there have been many other sites that now participate in this as well. We don't have a problem with arterial resection. It is definitely an aggressive local modality that helps treat the tumor. But I can show you here, the one thing that we did see was in those patients who went to surgery first, their 5-year survival is 20%. And in those who got neoadjuvant therapy with arterial resection, 5-year survival is 40%. Those are exactly the same data that are seen now to be going around, despite the modality that is used for the aggressive local operation. The only difference here is when you look at these data, and these are multiple series that have looked at arterial resection, is in some instances the mortality rates can be really high. And generally speaking, nationally, in most academic centers, the mortality from pancreatectomy is about 1% to 2%. So when you see things like 5, 6, and 13%, those are very high mortality numbers. And Dr. Trudy then published this very nice editorial, but what he showed was that in his hands, after a lot of experience, the mortality has now come down to about 5% in the last 6 years. By the way, that's still about 2.5 times higher than the national average, or about 3 times higher. And so the question is, are we seeing a 3x benefit in survival? And the answer is we're not. So we have to be very careful, I think, in selecting patients for arterial resection. There are also concerns with using radiation in the setting of vascular resection, especially the development of delayed pseudoaneurysm as well, which can happen. And it's really important to mention that a lot of centers that do this, they will advocate for total pancreatectomy because a leak can be highly detrimental to an anastomosed artery, especially in the setting of radiation as well. And total pancreatectomy, not a hard operation to do, but very hard for patients to withstand. This is divestment, and this has been popularized and described by Marcus Buchler. And Dr. Buchler in Germany actually would take divestment over neoadjuvant therapy and chemotherapy in the upfront setting, and has described basically skeletonizing both the right side and the left side of the arterial trunk. We certainly divest routinely the right side of the artery, but we don't divest the left side of the artery. And 360-degree arterial divestment, the one problem with divestment when it's like this is because you destroy the autonomic nervous plexus around these arteries, those patients have severe refractory diarrhea that can be really debilitating. And when we occasionally do that, we really suffer with the patients with this. But there are no good long-term data from divestment as yet, and I'm sure these will come in time. Really important to remember this. Whatever I said today is that the majority of patients still recur in the distant fashion. And we've looked at this over and over again, and we've found that it's about 80% distant recurrence rate and about 10 to 20% local recurrences. And this doesn't matter whether we do neoadjuvant therapy or not, and doesn't matter whether we do node negative or node positive patients for comparison. So the question then that comes up is, does this local operative approach matter? And really much of the benefit, I think, is still from the systemic neoadjuvant therapy. The biggest change that we've had is from better chemotherapy. I think that we still need some form of a local aggressive therapy, whether it's arterial resection or divestment or IORT. I think we do need to be aggressive in the bed in some way. And beyond that, I would say outcomes are largely similar, maybe some differences in morbidity and extent of resection and how the patients will perform afterwards. But the benefit is only seen from these local approaches once the distant metastatic patients have been excluded, and trials need longer follow-up for us to start to appreciate some of these effects that we're seeing in the bed of the tumor resection. So it's always great when you present your best case. I thought I'd actually give you my most recent case that we did with locally advanced tumor here. And again, one of those cases that you look at initially and just looks like a total bear. Locally advanced tumor, huge uncinate tumor, extends over to the left side, encases the SMV, encases the SMA. This patient, again, 10 years ago, had no business getting resected. CA99 of 560. And here's the dramatic response from chemotherapy, some continued fuzziness around the posterior aspect of the vein, still some substantial involvement around the artery. Again, we don't automatically resect vessels here. We go in and try and see what we can do and explore the situation. This patient definitely deserved an exploration. CA99 had normalized in this setting, which again is a strong predictor of resecting. And here's the SMV, cleanly resected, and underneath it here, the SMA, which was divested on the right side as well. Pancreatic stump, bile duct there, and this tumor came out cleanly. And this pathology actually just resulted in the last couple of days. It was a negative margin resection with minimal residual tumor as well. But we need to, as surgeons, even though I'm talking about chemotherapy being probably the best therapy that we've offered patients in the last 10 years, to continue to optimize the operation and have patients do better. We need to continue to study and improve our outcomes, minimize operative blood loss, reduce pancreatic fistula rates. I think we need to prehabilitate our patients. I think I made a good argument for that earlier when I showed you that 25% of our patients became more frail as the chemotherapy deconditioning occurred. And then we need to follow some of these enhanced recovery after surgery protocols that could help us expedite the care of these patients. And I just want to mention that I'm proud of having this study that has been delayed a little bit because of COVID, of course, but it's a multimodal prehabilitation phase 2 trial that I'm running. And it involves an individualized fitness program and nutrition optimization program. And I'm happy to talk to people who are interested in prehabilitation about this. But it's an interesting program because it's a tiered program that allows people to be selected into different groups based on their baseline abilities. And then we developed a prehabilitation telemedicine program during the COVID-19 era as well that involves exercise, nutrition, smoking cessation, and mindfulness. And with that, I'll come back to the question that I asked in my title, paradigm shift or smoke and mirrors? And I think it's probably a combination of both, unfortunately. So we have definitely done a better job at selecting patients and excluding those with bad tumor biology. And I think that might be the best that we could do with pancreatic cancer. If we can identify appropriately patients who will not benefit from an operation, then we will start to see the numbers that we're seeing with 5-year survivals of 40% and more. But that is the challenge, and I think that's still a win. I do think that we need some form of important local aggressive modality to help us resect those patients cleanly and prevent local recurrences. Those are really debilitating when they occur. And then the final thing to the residents is, while you're always taught to specialize and become really super selective in your academia, and it's hard to compete and things like that, I'm not a pathway person. I've not pursued one pathway of my life that I'll go down for being known for. But what I decided to do was attack pancreatic cancer and try and do it from all aspects that I could. We did this a little bit with basic science, and you saw some of the work that we published. We have a rigorous machine for analyzing and updating our institutional data. And then I'm proud to be a participant in a lot of the clinical trials. And with that, thank you so much again for having me back today.